we listened to him that our national immunization program of Government of India, which is UIP, what is known as, versus the schedule which we, Indian Academy of Pediatrics, has been advocating and publishing for the last so many years. So I hand over to Dr. Arun Wadhwa for his initial remarks, and then Dr. Kasi. Thank you very much. Dr. Arun Wadhwa, please.
Thank you, sir. Thank you. Thank you, sir. Welcome, everybody. I think most of the job you've done, Dr. Dubey, already. And I wanted to thank Delhi IAP for such a session at a very appropriate time, because most of the vaccines are now coming into NIP. And gradually, quite a few people shift from our clinics to NIP. And then after that, they come back once they realize that some of them are not being given. Or sometimes it's the other way around, people from NIP to IAP or IAP to NIP. So we need to know if the patient shifts. I think first we need to know what are the differences. Then after that, we will understand what we have to do once the patient is shifting from one to another schedule. And also, I'm sure Dr. Kasi will tell us why the two schedules are different. What is the rationale of having a different schedule in NIP and IAP? What are the considerations why one vaccine is introduced into NIP? And not like a normal routine, which is there in IP also. So there are lots of intervening things. And these days, people do shift from here to another, one system to another. So it's a very appropriate seminar today. And Dr. Kasi, you already introduced. He's the past member, then convener and advisor of ACVIP, which is the India body of vaccinology. And sir absolutely needs no introduction, our guru. Pranam, sir. Over to you.
Thank you, Dr. Dubey and Dr. Wadhwa. I'll just share my screen. What happened? No, I think I'll just share it again.
So, Dr. Dubey, I'll have to excuse myself for just 5 minutes. There's some child here with febrile convulsions, so I'll just be back in 5 minutes.
Yeah, no problem. I'm there. No problem.
Actually, we closed, but somehow the patient has come inside.
Okay, doesn't matter. So please attend the patient.
What happened?
Yeah, we can see your slide. The first
Can
slide,
you-
NIP versus IAP schedules.
Can you?
Yeah.
I'm unable to see it.
Oh, you are not able to see, but we
No,
can see.
I got it. Can you see the full screen?
Yeah.
Okay.
We can see. Yes,
Okay.
go on.
Thank you. At the outset, my sincere thanks to Delhi IAP for inviting me to this very exciting webinar, which I am going to discuss something that is at the back of almost every practitioner's mind. I would like to begin with offering my condolences to Dr. Anupam Sachdeva and his family for the recent bereavement. In fact, a couple of weeks ago, when Dr. Anupam Sachdev rang me up, he told me, I want something exciting, something controversial. When I told him, why not compare NIP and IAP schedule, he jumped to it and he said, yes, that is the topic I want. Of course, this is a topic which I have never spoken about, which I was always enamored about. And this gave me an opportunity to go through a lot of literature and come up with this particular presentation. One second, I can't. Yes. So, in today's talk, I'm going to discuss, is NIP adequate and are we overdoing thing as far as the IAP schedule is concerned? Or is it that NIP is a compromise less than adequate and the IAP schedule is adequate and all should have the IAP schedule? I will discuss initially the differences, the philosophy behind NIP and the IAP schedules. What are the differences? Why the differences are there? And please do not be surprised if the conclusions are something that you do not expect. Okay. Now, first, let's understand the differences between the NIP and the IAP schedule. In the NIP, the target is a community. The community is the center of everything. So what is best for the community? Whereas in IAP schedule, it is the individual child. what is best for the individual child. What determines which vaccine should be used? NIP, the basis is the epidemiology and the disease burden. The disease burden is something that is very, very crucial for deciding the inclusion of any vaccine in the NIP. For the IAP, it is a risk for an individual child. The community doesn't enter the picture very significantly. The aim of the NIP is to reduce the disease burden, especially morbidity, mortality, death, and healthcare utilization. Of course, for the IAP, all these things apply to the individual. But in addition, the IAP schedule also looks at certain indirect benefits and even prevention of minor complications. In the NIP schedule, the first thing that is considered is the cost. Can the government afford this vaccine? Next comes how efficacious it, and safety comes last. Whereas in the IAP schedule, it is the safety that comes first. Is this vaccine absolutely safe for giving it to my young patients? Then comes efficacy, and last comes cost. Because in the NIP, the government is paying for every single vaccine. The NIP schedule is provided free for every child in our country, whereas the IAP schedule, the parents or the caretakers bear the cost of the vaccine. Logistic issues are very crucial for NIP. Do I have the money? Do I have sufficient cold chain space? Do I have the infrastructure to transport? What about other materials required for the vaccine program? Do I have the healthcare personnel to take care to implement the program? All these things are crucial. Whereas for an IAP, this is really not very relevant because it is the individual practitioner who is going to buy and deliver the vaccine. Even as far as the schedule is concerned, there are certain limitations for the NIP. You cannot create new slots. The immunization rates are going to go down. So every vaccine has to be piggybacked on an exciting schedule. The number of doses, the interval of doses may be different in the NIP because the NIP adopts the most cost-effective way of delivering a vaccine. Whereas as far as the IAP schedule is concerned, there is a greater flexibility. New slots can be created. You can call the patient for the influenza vaccine at 6 and 7 months. You can call a patient for the hepatitis A vaccine at 1 year, but creating these slots in the government schedule is going to be very, very difficult. And generally, the IAP schedule recommends the most immunogenic and efficacious schedule, not the immunogenic and schedule which is just efficacious and just sufficient to serve its purpose. So these are the basic differences with the NIP and IAP schedule. We must remember that both they do not exclude each other. They are something that is complementary to each other. So let us put our minds and think about it in this particular new way. So what decides which vaccines? Epidemiology and the disease burden. And of course, what is the schedule? I just discussed what are the considerations for deciding on the schedule. Now, coming to the absolute differences, let's take the different vaccines. BCG, I'll just put my pointer on. Yeah. As far as BCG vaccine, there are two differences. NIP says still 1 year, IAP stays still 5 years. In the NIP, there is no provision for revaccination for an absent scar, whereas the IAP says you may repeat BCG vaccination once in those who do not have a scar till at least 6 months following the vaccination. Of course, we are all aware of the difference between the OPV. In NIP, the OPV is the primary vehicle for protection against paralytic polio. Whereas in IAP, we give only a single bird dose. Lot of differences both in the route of administration and the schedule between NIP and IAP. Same with PCV. We have the same vaccines, but different schedules. Let's discuss that. HIB, NIP does not provide a booster. IAP says a booster should be given. Rotavirus is another vaccine. There's a lot of difference in recommendations. In the NIP, you can give the first dose till 1 year of age, whereas IAP says till 14 completed weeks. The final dose in the NIP can be given till 2 years, whereas in IAP it can be given till 32 weeks of age. Of course, as far as measles containing vaccines, NIP says only MR 9 and 18 months. IAP says MMR at 9 months, 15 months, and 5 years. And a host of other vaccines, typhoid conjugate, influenza, HPV vaccine, hepatitis A, varicella, which are not included in the NIP but are included in the IAP. So of all these, I will not discuss about OPV because we all know, we have heard a lot about it, why IAP has not recommended any dose of OPV beyond the birth dose and the SIS. I'm also not going to talk about MR and the vaccines that have not been included because that will form a totally separate topic. So let's discuss BCG, IPV, PCV, HIB, and ROTA in this particular session. Why should you stop vaccinating BCG at 1 year? Why not till 5 years, or why not till 10 years? If you look at the tuberculin test, this was a study done in young adolescents in South India. This was from Bangalore, where they looked at age groups from 11 to 18 years. 10 millimeters induration was taken as a cutoff between BCG induced and infection. If you see, as age progresses, the number of individuals who are positive of more than 10 millimeters keeps on increasing. So the incidence of infection increases with age. This is something we all know, but this is something that has been documented. If you look at the annual risk of tuberculosis infection, this was a large study done across all the 4 zones of the country in children between 1 and 5 years, 1 and 9 years. And the incidence is quite high, 7.8% prevalence at the national level, varies between zones. And the annual risk of tuberculosis infection, ARTI stands for annual risk of tuberculosis infection, varies, it's about 1.5%, which is a very, very high figure. And between 2 surveys done about 10 years apart, there's really been no statistically significant changes in either the prevalence or the annual risk of tuberculosis infection. And these findings indicate a very high rate of transmission of tuberculosis in the community. So should we restrict at 1? Can we continue till 5 years? Now, this was a large study where they looked at the incidence rate of tuberculosis in our country, age group wise, at different years. It covered a period, almost 6 studies. And if you look at this, the incidence between 5 and 14 years doesn't increase too much. Somewhere in late adolescence, it starts increasing, and becomes very high in the elderly. So why should we stop at 1? Why not continue till 5? The second issue is NIP says no recommendation for repeat BCG when a scar is negative. IAP says 1 repeat dose of BCG may be given in those who are scar negative. What is the reason for the IAP recommendation? Let's examine the data. If you look at the BCG scar failure rates, it's very variable. Various studies from our country has provided different figures, but on average, it is about 10%. And we must remember that development of BCG scar depends on many factors apart from the vaccine. What is the strain? Strains like the Denmark strain, the Copenhagen strain, the Glaxo strain, the Tokyo strain are highly immunogenic. Scar formation is much higher in those strains. In India, I think the Serum Institute vaccine utilizes the Moscow strain. It depends upon the injected dose. Scar formation is better with 0.1 ml dose versus 0.05. The technique has to be proper intradermal with that bleb of 4 to 5 millimeters. Improper technique will lead to less BCG scar formation. Of course, programmatic factors like quality of the vaccine, transport, storage. Does the vaccinee has some undiagnosed underlying immune condition? And studies have shown that even when you give OPV along with BCG, there is some reduction in the scar formation. So coincident vaccines and micronutrient deficiencies can also affect the scar formation. So now, does scar formation failure indicate absent immunological response? We have a very interesting study done in Hyderabad by Rani et al. way back in 1990, late 1990s. They took 655 children, gave the tuberculin test. 591 of them developed a scar. That means scar formation occurred in about 90%. So they took those who did not have a scar and those who had a scar and did a laboratory test for estimating the cellular immune response to tuberculosis antigen, and that was called the LMIT, lymphocyte migration inhibition test. And what does this show? That of those who did not respond, 80 to 94% responded with a positive test. That means if you give BCG for 100, 90 will develop a scar. Of the 10 who did not develop a scar, at least 8 or 9 have evidence of a cellular immune response. So of the 100 which started, 98 will have either a scar or laboratory proof of immunity, which is very good for any vaccines. And if you look at these figures, scar formation, okay, is highest when you give the vaccine beyond the first day of life. And even the lymphocyte migration inhibition test has been highest in those where the vaccine has been given with the first 1 month, lower in when the vaccine has been given beyond 1 month of age. So absent scar does not mean an absent immunological response. Probably in all cases, it indicates a positive immunological response to the vaccine. So why revaccinate? Another issue which used to be considered is that, so with this we can say that BCG scar preference may be an important marker of the program quality of vaccination. How good is the quality of the vaccine? What has been the storage conditions? What about the technique of give? More to do with that rather than the vaccine itself. Second, what is the relationship between BCG scarring and improved child survival? In fact, there were 6 studies from Guinea-Bissau in West Africa. All of this looked at the mortality rate in those who received BCG but who developed a scar and did not develop a scar, and certain very, very startling revelation. Having a BCG scar versus no BCG scar was associated with a mortality rate ratio of 0.61. So having a scar improves the mortality, reduces the mortality rate by almost 39%. This effect was strongest in the first year and second year of life, and in children who received the vaccine in the neonatal period versus those who received after the first week of life, or after the first month of life. A very, very statistically significant difference. This effect could not be explained by protection against tuberculosis because tuberculin conversion was almost similar in those who had a scar and did not have a scar. So the scar formation or the scar positivity is more a marker of the non-specific effects of BCG. And the lower mortality differed significantly by cause of death, and it was strongest for respiratory infections. The mortality rate reduction was almost about 80%. So it is very comforting to see a scar taking all these things into consideration. So in the words of Dr. Jacob John, which was published in 2000 in Indian Pediatrics, since it is clinically impossible to distinguish between failed vaccination and failure to develop a scar in spite of an immune response, the better clinical option is to inoculate BCG a second time. There is no harm. In fact, studies have shown that even in those who have got BCG a second time, it does not affect the interpretation of the MANTU test also. And so BCG till 5 years, there is strong grounds for it. Repeat BCG for scar failure also, there are fairly reasonably strong grounds for it. And that's where the IAP program schedule probably is a little more advantageous as compared to the NIP program. Let's come to IPV. This is something that is a very, very hot topic of discussion because of the lot of changes that are occurring in the schedule in the National Immunization Program. So there are two issues to be discussed. One is the route, fractional versus full dose intramuscular, and the schedule. The present schedule, all are aware, is intradermal 0.1 ml at 6 weeks, 14 weeks, and 9 months, versus what the IAP follows 6, 10, 14, a booster at 16 to 18 months, and a booster at 4 to 6 years. In this talk, when it mentions FIPV, it means fractional. When it says only IPV, it means full dose intramuscular IPV. We all know that IPV, even in an EPI schedule of 6, 10, 14, is highly immunogenic. This is figures taken from Plotkin's textbook of medicine, which shows that across studies done in different developing countries, the seroconversion rates are in excess of 90% and quite good GMTs also following the vaccination in an EPI schedule of 6, 10, 14. This is for full dose IM-IPV. So compared to the conventional schedule of 2, 4, 6 followed in most of the developing countries, the EPI schedule gives almost comparable seroconversion rates, but definitely the GMTs are much lower. We will discuss subsequently what is the importance of higher GMTs. This was a study done in Philippines where they compared the immunogenicity, both the seroconversion rates and the antibody titers in FIPV and IMIPV at 6, 10, and 14 weeks. So direct comparison of fractional versus intramuscular in the same schedule. As you can see, the seroconversion rates against all the three polio types, the SPR was taken as greater than 1 in 8 titer. There's practically no difference between the fractional and the full dose IM. But if you come down to the antibody titers, look at the difference between fractional and IM, both as far as the post-primary is concerned and the difference in the post-booster. In fact, in the post-booster, differences are much, much more, 2 to 3 times versus the FIPV. So, seroconversion rates 6, 10, 14, both are equal as far as seroconversion, but antibody titers are far higher with the intramuscular full dose versus the fractional dose. In fact, when FIPV in the new schedule of 14 and 36 weeks, 2 doses of fractional was considered, it was as good as giving 3 doses of fractional or 3 doses of IMIPV, except for type 3 where the seroconversion rates were lower. Now comes the question, are higher antibody titers of any benefit? We must understand that post-booster antibody titers are higher in people who have a stronger primary cell immune response. Remember, during the germinal center reaction, what comes out are both the plasma cells, both short-living and long-living, and the B memory cells. So, higher the number of antibody-producing plasma cells, higher is going to be the number of the B memory cells. In fact, this has been seen and proven and studied with hepatitis B vaccines. And there is no reason why this should not apply to polio also. So higher antibodies means higher B cell memory cell count, and that will indicate a much stronger anamnestic response and a longer persistence of antibodies following the repeat exposure. So it is favorable to have higher antibody titers. In fact, another advantage is we all know that mucosal immunity is very crucial for halting poliovirus transmission. We always consider that secretory IgA is the hallmark of mucosal immunity. But we must also remember that IgG antibodies, which transudate from the serum into the pharynx or the mucosal interstitial mucosa, also adds on to this mucosal immunity. In fact, this study clearly shows that those which had the highest titers of antibody in the blood shed the least amount of virus when they were challenged with a monovalent oral polio vaccine. So we have two definite advantages of having higher antibody titers. So these things are advantages for at an individual level, and that's the reason why the IAP has adopted this schedule. Now, if you compare various schedule, 2 doses and 3 doses of both fractional dose and intramuscular, the violet colored curves are 3 doses of full dose. The red is 2 doses of fractional dose. This is 3 doses of, this is full dose, 3 doses, 2 doses, fractional dose, 3 doses, 2 doses. And here the schedule of 2 doses is 14 and 36 weeks, and 3 doses is 10 weeks, 14 weeks, and 13 weeks. It's not a 6, 10, 14. In spite, so what did the GMTs at 40 weeks, that is 4 weeks after the last dose, in case of the 3 dose IPV, were higher for all the 3 serotypes versus the fractional dose 2 or 3. But if you compared 2 dose IPV versus 3 dose IPV, the 2 dose IPV gave higher antibody titers for 1 and 2, but not against type 3. There was no statistically significant difference between these titers. So in general, we are having much higher, significantly higher antibody titers with a 3 dose schedule versus a 2 dose schedule as compared to the fractional dose IPV. In a meta-analysis done regarding the antibody response following 2 or 3 doses of fractional dose versus 2 full doses of IPV, generally the antibody response favored the full dose and never the fractional dose. So showing that 2 or 3 doses of IPV schedule induces higher antibody titers compared to 2 or 3 doses of the fractional dose. So the point that I need to emphasize is that more number of doses during the priming and more boosters will give rise to higher antibody titers, longer persistence of antibody titers, and probably marginally better mucosal immunity as well. Now, the NIP schedule has fractional dose as 6 weeks, 10 weeks, 6 weeks, 14 weeks, and 9 months. There is nothing to state that the 9 months is a booster dose. But we all know that the 6 weeks and 14 weeks are the priming, and any dose that you give at least 4 to 6 weeks later can be taken as a booster dose. Okay. So with that into consideration, do we need a booster at 4 to 6 years as the IAP recommends? Now, this is a study which looked at what happens to the seroconversion and antibody titers after the toddler booster, that is after the 16 to 18 months booster. For all the 3 polio serotypes, the reduction in seroprotection rate is very minimal. But if you look at the antibody titers, they really drop very, very significantly by the time it is, when the time has come to give the preschool, that is the 4 to 6 years booster. So there's a very rapid drop in antibody titers between 16 to 18 months and 5 to 6 years. Now, when you give a preschool booster at 4 to 6 years, the seroconversion rate becomes uniformly 100%, and there's a tremendous 10 to 20 times increase in the antibody titers. When you follow up these children, very high levels of antibody titers have been shown to be maintained at least for 5 years after you give the 4 to 6 years booster. So, as I said, since we consider antibodies important, giving a booster at 4 to 6 years also very important. Another very interesting study done in Germany. They took 3 cohorts. A cohort which received a booster, the yellow, at 4 to 6 years who were not boosted, 7 to 9 years who were not boosted, and 7 to 9 years who were boosted. Okay. This is 4 to 6. The brown hatched is 7 to 9 not boosted. So in this particular group, non-boosted, although the seropositive rates remained over 90%, it was somewhere around 91 and 91.2% for type 1 and type 2, but not very much low for type 3. You compare that with the 7 to 9 years who were boosted, it was uniformly 100%. So definitely a booster at 4 to 6 years improves the seroprotection rates as well in the vaccinated individual. So from this point of view, it has been recommended. I have taken this verbatim from Plotlin's textbook of vaccinology, that it has been recommended that a minimal position would be to recommend 4 to 5 doses of an IPV containing vaccine, with the last one administered at school age entry. In fact, data shows that if you're given a choice of using only one booster of injectable polio vaccine, it is better to give it at preschool entry rather than give it in the end of the toddler age groups. So that is the importance of a school age booster, and that's the reason why in 2020 the ACVIP recommended that a second dose of an IPV or IPV containing vaccine should be given between 4 and 6 years. So those are the differences as far as the NIP and the UIP is concerned, right? Now, another very important vaccine where there is a lot of doubts. What happens when they change out a NIP to IAP? What happens when they change from IAP to NIP? Because NIP gives 2 priming and 1 booster. IAP says 3 priming and 1 booster. So here we'll consider 2 separate issues. How good is 2 priming doses? How good is 3 priming doses? And what is the role of booster in those who have received 2 priming and those who have received 3 priming? That will answer most of our questions regarding the interchange between the NAP and IAP titers. The need for a schedule depends upon the epidemiology of the disease. How soon does that infection occur in the community? This is a graph which compared the incidence rates in US and South Africa across different age group in months. The dark lines are South Africa, which is a developing country. The light lines are US, developed country. If you notice in the first 9 to 12 months, almost all the bars are dark in color. The light bars start increasing only in the second year of life, indicating that in developing countries, peak illness occurs almost by 6 months of age, whereas in developed countries, it is in the second year of life. There have been many studies in India which has looked at the age-related seroepidemiology of IPD, of invasive pneumococcal disease. When the different values were smoothened out by statistical methods, you find that the peak is somewhere between 4 and 6 months of age, indicating that we need very early protection against pneumococcal disease, both the invasive and the mucosal diseases. There was a very interesting systematic review of the effects of PCV dosing schedules on immunogenicity way back in 2014. These were all WHO sponsored because that was the time WHO said that, all should, even the developing countries, the low income countries should include the PCV vaccine in their routine immunization schedule. So when you compare 3 priming, so now I'm comparing 3 priming versus 2 priming. Let us forget the booster. When you give 2 doses versus 3 dose priming schedule, the immunogenicity is far higher with 3 priming doses versus 2 priming doses, except for serotype 1, where there is no difference whether you give 2 priming or 3 priming. So point number 1, 3 priming is definitely superior to 2 priming as far as the immunogenicity is concerned. Second, they looked at the antibody titers just before the booster, that is somewhere around 12 months of age. And they looked at the post boost, somewhere around 18 months of age. Something surprising, irrespective of the number of doses giving the priming, whether it was 2 priming or 3 priming, the pre-boost and the post-boost titers were almost similar. So whatever difference is there between the 3 priming and 2 priming does not persist for more than the end of the first year of life. It's for a very short duration. But how important is that? We will consider that very shortly. When do you give the first dose of pneumococcal vaccine? Did not affect the post-primary GMD. In fact, there are papers which show that even a PCV given in the neonatal period is very, very immunogenic. What is important is the interval between doses. Now, when the interval between the doses was 2 months, antibody titers against 23F, 14 and 6B were far higher than those where the interval was 1 month. As far as serotype 5 and 1 was concerned and 19F, there was not much of a difference. So increasing the interval with 2 months is definitely better, right? Now, when you look at what happens to the titer from pre-booster to post-booster or post-primary to post-booster, whether you give 2 or 3 doses, there's a remarkable increase in antibody titer, and there's really not much of a difference. Again, emphasizing the difference between 3 and 2 priming doses is only for a few months after you finish or till the end of the first year, that's all. In the second year and following booster, there are no differences. So when you compare the 3 plus 0 plus 2 plus 1, now is it sufficient? You know, WHO has suggested 2 schedules for developing countries, where the peak incidence of pneumococcal disease in the first within 6 months of life, they have advised a 3 plus 0. That is, you give 3 priming without any booster. Where it occurs towards the later part of 6 months or in the second half of the year, they have suggested a 2 plus 1. And that's the reason why India has adopted a 2 plus 1 schedule. Okay. So basically, a booster is necessary because in the second year of life, the 2 plus 1 schedule had far higher antibody titers compared to the 3 plus 0 schedule. Now, taking all this immunogenicity into consideration, there was a paper which was published again in 2014. You looked at considerations for policymakers. What were the differences? Post-primary, 3 doses results in a better immune response than 2 doses for most serotypes between 6 and 7 months. The differences are largest for 6B, which is about 21%, and for 23F, which is about 17%. For all the others, the difference is no more than 7%, 2 doses versus 3 doses priming. When measured at about 1 year of age, before a booster was given, there was no difference whether you gave 3 priming or 2 priming. That was, we talked about immunogenicity. What about actual clinical endpoint parameters? This was a study done with PCV7 in US, where they looked at the incidence of LRTI following 2 doses and 3 doses. And what they found that when 3 primary doses were given, the admission rate was 9.5 per 100,000. But when only 2 doses were given, it was far higher as 17.3. So there is definitely a benefit in giving 2 doses. But this difference was seen only in the year 2002. If you remember, PCV7 was introduced in 2000 in USA. This study was done in 2002. But in 2003, there was no difference whether you gave 3 or 2 doses, indicating that when population coverage increases and there's herd immunity, whether you give 3 doses or 2 doses does not make any difference. As far as India is concerned, the PCV coverage in our country is somewhere around 35%. We are still a long way off from developing herd immunity, and hence more number of priming doses are important at this particular stage. Now, is there any difference in nasopharyngeal carriage? In the first year of life, in 3 doses, the nasopharyngeal carriage were generally a little higher compared to 2 doses. But when you looked at the second year of life, the carriage rates was almost similar. So compared to the immunological response, even the carriage rate is better in the first year when you consider 3 versus 2. But after the first year, it becomes the same. Now, are higher post-primary titers important? Here, I would like to mention that most of the titers, 0.35 microgram per ml, is against IPD. You must remember that prevention of mucosal infection needs much higher antibody titers. As far as PCV7 was concerned, 0.35 microgram was important for prevention of IPD, but they have estimated that you require levels of 3 to 5 microgram to prevent mucosal infections. And Pneumonia, which is the mucosal infection, is a far, far greater public health burden in our country as compared to IPD. So definitely higher titers are going to be beneficial. Now, do we find these mucosal infections in the first year where the antibody titers are higher? The Pneumonet study till today is the only population-based study of IPD in our country. Although it was a small study with just 41 isolate, still it gave us some very, very important data. If you look at the estimated incidence rates of invasive disease, it was very high in those less than 6 months and 6 to 12 months. So in the first year of life, you have one of the highest incidence rate. It comes down dramatically once you enter the second year. Now, if you look at the incidence of pneumonia, clinical pneumonia, X-ray, confirmed pneumonia and X-ray confirmed pneumonia with a CRP of more than 40, which confirms a bacterial etiology. If you look at the incidence rate, it was highest in those less than 6 months. Hence, it is very imperative that we should have much higher antibody titers in the first 6 months in our country, considering this data of mucosal disease like pneumonia. And hence, a 3 priming dose schedule is definitely advantageous as compared to the 2 priming doses. Second, why do we need a booster? WHO said 3+0 is fine. Why do we need a booster? Now, this is a study from the old India INCLEN study, which looked at pneumococcus and Hib incidence in our country. And what they found that the incidence of type 1 is higher after 2 years and up to 5 years. And this is not true just for type 1, even type 6, even type 14. So you require protection in the second year, and a booster given towards the end of the first year or in the second year is going to give an anamnestic response and much higher antibody titers, which will go on almost till 4 to 5 years. And hence, with a high incidence of type 1 in our country, there is definitely a need for a booster of the PCV. In the first year, if you're giving a 2-dose schedule, in the second year, if you're giving a 3 priming dose schedule. So that is as far as PCV. The third major difference with the NIP and HIB is that, and IAP is that there is a booster of HIB in the IAP schedule. There is no booster of HIB in the NIP schedule. Now, this was a study which was done, a population-based study, which was done in our country regarding HIB infections before the introduction of HIB vaccine. And this showed that 78% of infections occurred in the first 1 year, but almost a quarter occurred in the second year. And as I said, the NIP will adopt what is most cost effective. Since the major burden was in the first year, the NIP adopted a 6-10-14 without a booster. What will be the end result? Let us look at the HIB experience in UK. UK also introduced a 2-3-4 month schedule in 1992. There was a dramatic fall in HIB incidence, especially in the vaccinated cohort. And those who were very close, so in those less than 1 year and those 1 to 4 years, although there was some reduction even in those between 5 and 14 and those above 15 years. Everything went on merrily, but 5 to 7 years later, HIB started increasing, especially in those who were not vaccinated and even in those who were vaccinated. Looking at this, a booster of HIB was reintroduced in 2013, and subsequently again the levels have gone down to baseline, except for the above 15 years where probably the herd effect is not very effective. So the UK now has changed over to 8 weeks, 12 weeks, 16. They give a hexavalent vaccine and they give a booster of a combination of HIB with meningococcal C at 1 year. So we will probably follow the same schedule, maybe after 8 years or 10 years. Unless we have surveillance going on, we may never come to know whether there is a resurgence of Hib later on in those who have not been vaccinated. So definitely there is a need for booster to preempt this resurgence of Hib a few years after vaccination. The last point I would like to discuss is about rotavirus vaccines. Now, in the NIP, rotavirus vaccine first dose is given till 1 year and the final dose is given till 2 years of age. It has been hammered into our minds that interception increases if the first dose is given after 14 completed weeks, or you complete the schedule after 8 months or 32 weeks, because after 8 months, there's a natural increase in the incidence of interception. So IAP says stick to the age restrictions, whereas IAP is more relaxed. Now, why did the NIP start this relaxed schedule? It was based on a paper by Manish Patel from the CDC, which was actually a modeling study, not a field trial, where they said that administer the first dose to infants up to 1 year of age would prevent an additional 54,000 rotavirus associated death, while potentially resulting in an additional 1,226 interception deaths. The risk-benefit ratio was almost 40:1. That is why the WHO said even further that you can give the first dose till 2 years, although the NIP says till 1 year. Now, as we all know, right from 2014, in a phased manner, rotavirus vaccines have been introduced in our country. For the last 4 to 5 years, every child in our country who goes to the vaccination post gets the rotaviral vaccines. There were sentinel studies to look at the interception rates before vaccination and after vaccination. In fact, before vaccination, to find out the background incidence of interception, large studies were done. After 2 years of use of Rotavac, the sentinel study was published in New England Journal of Medicine, and the results were very, very surprising. With the age relaxed recommendation, the relative incidence of interception of the first dose was 0.83, less than 1. Even after the second dose, less than 1. After the third dose, 1.08, which was not statistically significant. There was no increased risk of interception in the community in spite of the age-relaxed recommendations. Now, why has IAP not adopted it? Because IAP wants to give the safest positive schedule. This data is only for Rotavac. A similar study is also occurring for Rotasil. It does not apply for the imported vaccine, that is Rotarix and Rotatec, because it is confusing to have differential recommendations for the same vaccines against the same illness. The IAP has stuck to the old recommendations where there is a lot of age restrictions. So to conclude, there are other differences, but I've just taken the major differences. From the community health perspective, the NIP is adequate. From the individual child's perspective, the IAP schedule is adequate. Confusion arises when we try to mix and match the two schedules. We should try to avoid it as much as possible. Of course, if the situation arises where you have got to mix and match, there are certain recommendations which have not been really published, but which are basically expert opinions. We can take that up in the subsequent question answer sessions. Thank you very much. I'll be very pleased to answer any questions if there are any.
Thank you. So,
Thank you very much.
that was
Yeah,
really
Dr.
great. So, Dr. Dubey, you're taking over the questions?
No, all right. You go on, and then I'll later on.
So, Dr. Kasi sir, it was a real treat listening to you, and so many new things have come up. And I think we can also have a second part of it where we can include the MR, MMR, the type of vaccine, the single dose HPV, by then it will be there. So maybe
Yes,
why government HPV single dose, why double dose? So, we really can have another part two of
I
this
know.
talk.
I
Another
did not include HPV because it is still not in the schedule
Yeah, not
already.
in the government schedule. Yeah, right.
Yes.
even MMR and typhoid we can add.
Yes. Yes.
So I think there's just 2, 3 questions. One very interesting question is, like you said, full dose IPV is better than fractional IPV. Does it hold true for rabies also?
No, I think that is where the difference comes. As far as IPV is concerned, fractional dose is a cost-saving intervention, and where there's a shortage of the vaccine, you try to vaccinate more population. As far as rabies vaccine, I feel a little hesitant to talk in front of Anurag Agarwal about rabies. But studies have compared, full dose rabies vaccine with intradermal for PEP specifically, and they have found that in the first 10 to 14 days following vaccination, ID gives higher antibody titers, but by 2 to 3 weeks, IM takes over and then the antibody titers are higher. So as far as rabies, I don't think we are right in saying that ID is inferior to IM. Am I right, Arun?
Anurag,
Anurag, any
Yeah,
comments?
yeah, I totally agree with you, sir. And it is exactly as you have said, multiple studies have been done by various pharmaceuticals, with various brands, and they have got a nearly similar result. So this was surprising for me also, ki why this is so with rabies vaccine, but not so with IPV. And in fact, in rabies, we say that ID route is nearly equally long-lasting protection as compared to IMD. That is the reason we are continuing with ID route in government.
Right.
अनुराग योर वॉल्यूम इज लो थोड़ा कुछ वॉल्यूम बढ़ा लेते अगर तो
नहीं, उसका वो बास एंड वो इफेक्ट थोड़ा गड़बड़ है। ये बाहर बैठे हो ना, देखो जंगल में।
रेबीज प्रोन एरिया में
कंबोडिया में।
सर ये मॉर्निंग साइकिलिंग के लिए जाते हैं तो सनराइज दिखता है सर।
So that's the second question is also there's one difference in the BCG amount, so as 0.05 or 0.1, the guidelines may be a little different in different places. Somebody's asked that question, which should be the one which is used?
I see the reason why 0.05 has been recommended those less than 1 month is, at that time, it was considered that technically it is more difficult to give 0.1 ml in a newborn and raise a good enough wheel, whereas it is more convenient with 0.05. Studies have also shown that 0.05, the incidence of lymphadenopathy is less than 0.1 ml. But if you look at the scar formation and the tuberculin reactivity, it is better with 0.1. And I think now almost everyone gives 0.1 only now.
Actually, I've always given 0.1, never given 0.05. Lymphadenopathy has never been a problem.
Yes.
In fact, in government, we are giving 0.05.
Exactly. That is the recommendation by the NIP. IAP has also followed the recommendation but from whatever discussions I've had, I think a vast majority of the pediatricians are giving, 0.1 uniformly to everyone beyond in the neonatal period.
Is there any increase in the adverse events if you revaccinate? So you said that the scar is not there. The mother is certain that the vaccine was given, so we may not revaccinate.
No,
that is what we have been following.
No, if the
So
second
there
dose
any increase in
is
the adverse events.
no, sir, if the second dose is given with the proper technique, there is no increased incidence of adverse effects at all. In fact, this need for a repeat BCG in the absence of a scar, neither does the government recommend it. Even in WHO, if you see the BCG, there is nothing mentioned about a second dose of BCG at all. It is only the IAP which is talking about a second dose. I mean, I literally had to search the literature for justification of this particular recommendation, and I came across these things in the literature.
Okay.
So what do you think about this IPV 18 months booster? Can the IAP do away with this? Although we don't have a vaccine which would come without IPV, but since fractional IPV 3 doses, and suppose we have given 3 doses of IM IPV in the primary series, can we do away with the 18 months booster straight away?
Yes, there are studies which have looked at the persistence of antibodies follow up to preschool age, following 3 primary dose and 3 primary dose plus 1 booster. The difference in antibody titers are not very, very different in those who have received a booster at 1.5 and those who have not received a booster. But giving a booster in the preschool period is crucial because that is the one where you're going to get a very strong anamnestic response. And remember, if you're given the first booster and you give the second booster, the anamnestic response following the second booster is much higher in those who have received the first booster versus those who have not received. So if you are given a choice of only one booster, stick to the preschool. But if you say you can give more than one, then I think retaining both is definitely advantageous.
Will last longer unless we start
Yes.
PDAP IPV booster.
Yes. In
So,
fact, fractional dose IPV, there is so much of work being done. In fact, there have been studies from Cuba where they're given 0.1 ml intramuscular. You see, and the anamnestic response has been as good as giving the full dose IM. So, but the only thing is in all these studies, they're looking only at the seroprotection rates. They are not considering antibody titers because a general concept as far as polio is concerned is that once you have seroprotected, even if you don't have antibody titers persisting in your blood, you are guaranteed against paralytic polio following any subsequent exposure. So that's the reason why in most of the publications, except for publications which come from the West, no one talks about antibody. They just look at the seroprotection rates, which I feel is a little incomplete.
So there are two more questions. One is an anonymous attendee who wants to know that if someone is following the NIP schedule in between wants to administer vaccine which are not there in NIP, what to do? So I think one should give it. The ones which normally are not there is hepatitis C,
Age
hepatitis
appropriate
C,
you can give.
TCV,
Yeah, no
chickenpox, you can shift.
problem.
And they want to know about meningococcal, which may not be required. MMR, of course, you should give, especially seeing
Yes.
the epidemic now. So give
You see,
one at 5 years of age.
we are all, crying horse that measles mumps should be included,
Yeah.
included. Now, from the government point of view, mumps is not a public health burden. Mumps does not cause hospitalization. Mumps doesn't cause much of healthcare utilization. Practically no child dies of mumps. Long-term sequelae are very less, versus measles and rubella. Addition of the mumps component is going to increase the cost of the vaccine.
Almost
So
5.
what the government looks at is, should I spend the money for mumps or should I spend the money for, say, typhoid or HPV? That is how they prioritize.
Yeah,
And taking that into consideration, mumps is not important for
I
them.
was about to ask you, suppose in the next Lok Sabha, you're the health minister. And if you have to add, which one will you add? MMR, TCV or HPV?
I think I would like, it'll be a difficult choice between typhoid and HPV, but probably HPV first because cervical cancer you cannot treat, whereas typhoid can be treated. So if you give me the order, HPV first, typhoid second, and then mumps, as far as I'm concerned. But HPV and typhoid are almost equal.
Maybe typhoid is more
Recently, people have seen
common.
surge of mumps cases. No? There have been, many reports that mumps have increased, and IAP has also written that rather than MR, please
See,
do
the
MMR.
problem is mumps has always been there in the unvaccinated, but now there has been a very, very large growth rate across the entire country. So
Yes.
I am not aware of any studies which have looked at the genotype. You see, in many countries, there's a change in the genotype. In most of the countries or Western countries where they've used the Geraldine strain, most of the mumps are genotype G. I have some older studies have looked at, genotype C in our country, but I'm not aware of any study in the recent epidemic that has occurred, outbreak that has occurred. So it may be something that is isolated, whether it is some post-COVID like what we have seen, adenovirus, etc. I mean, it's open to question.
Yeah, maybe if it persists or continues for a longer period, maybe the government may have a
Yes, sir. Yes.
Or if the cost
I take this opportunity to welcome another doyen of immunology and immunization, Dr. B. Rajshekhar from Visakhapatnam. Welcome, sir.
Good evening, sir. Sir, Doyen is both Doyens are there, sir.
This
Dr.
is one more.
Vadva sir and Dr. Kasi sir.
There is one more question. There is one more question. Dr. Rajshekhar is typing the answer. The person has asked that the one patient has taken PCV10 in the government, say first dose or second dose, after that wants to shift to PCV13. Or if he has taken the primary series as PCV10 in the government and now wants to take booster of PCV13, should we go ahead? I think there's
Definitely.
no...
There are studies done in Czechoslovakia where they have looked at boosting with, for PCV10 priming, boosting with PCV13 and vice versa, priming with PCV13, boosting with PCV10. So those have received PCV10 in the priming. If you give a booster of PCV13, remember you're giving the booster in the second year of life where you require less number of doses. Excellent anamnestic response to the common serotypes, and you get a very good response to the additional serotypes as well. Definitely a good idea.
Any other questions somebody wants to ask? Dr. Raj, any comment?
Sir, first of all, one question. Sir, we are talking about the BCG. Whether immunogenicity 0.05 and 0.1, is there any difference? If there is no difference, we can continue with the 0.1.
No, there is no. They have not studied immunogenicity. They just looked at the reactogenicity. I am not aware of any study which has looked at immunogenicity.
Actually, it's more of a T cell response, which is very difficult to measure quantitatively. So antibodies would be easier. Actually, if you see theoretically, 0.1 should be better if there are no increased side effects.
So 0.05 less than, we can go further.
Yeah, less than 1 month, 0.05. Beyond 1 month, 0.1 ml.
Sir, I thank Dr. Alok sir to give such a wonderful opportunity for us to be with Dr. Kasi sir, Dr. Arun, and Dr. Anurag and Dr. Dubey. I got the link after some time back only, just because I was lucky to join it. Get the link around 7:45. So listening Dr. Kasi sir, Dr. Anurag is always a pleasure and always a privilege. More learning. I ask him always where he gets the literature.
He has a different laptop.
That's why.
No. Actually, my son is a pediatric pulmonologist in Emory University. So they have access to every journal in the world. So if I need something, I just send the link to him and then he sends me the article. So
you have done a lot of research in this field, I must say. A lot of studies have been, you have pointed out from the various parts of the world, in fact. So very well done. I think very nicely prepared lecture. So thank you very much for a wonderful presentation. And I think all of our, whosoever has attended, our members, they have benefited a lot. And next time we will have other vaccines also in the same webinar. Similar. And Dr. Kashi, we would again welcome, and maybe some other speakers as well. So thank you very much, and thanks everybody who has joined us and who have asked questions, and all the panelists. Thank you very much.
Thank
you. Whoever
you.
has not attended their loss.
Yeah.
Thanks Delhi IAP for
sir, always tell new things every time. New things.
Yeah, we always learn something here. Certainly, no doubt.
That's true.
To log into next.
Thank you very much. I think can we